Okay, great. Thank you very much. So it's a pleasure to be here today, and I'm very excited to talk to you about the work that we do in the Clinical AI Lab. Excuse me for my voice, I'm just recovering from losing my voice last week. So I want to give you a bird's eye view of what we do in the lab, and maybe moving away from the buzzwords and the hype around AI in healthcare, also introduce you to some of the key technical concepts and methodological approaches that we do in order to enhance AI for healthcare. And believe it or not, in the research domain, a 1 or 2% increase in model performance is an achievement. And let's see how that is done. In order to contextualize the research that we do, I thought it would be a good idea to also mention something that you all might be familiar with, which is how much the UAE is investing in AI, which really drives a lot of the work that we do as well, because within the ecosystem, we do feel that we're well supported, and there's a huge and enormous actually support for innovation in AI. And this is why we're pursuing the work in the region for the region. So to begin with, in the Clinical AI Lab, we work on developing smart diagnostic and prognostic systems for different medical applications. They vary from in-hospital decision support for deterioration prediction, to stroke risk prediction, to supporting IVF treatment and monitoring of embryo development. So the medical applications really vary significantly based on the collaborators that we work with. And we work very closely with radiologists, with clinicians, and with others who are interested in pushing this field forward. But really the key goal here is to develop novel AI solutions from a methodological perspective so that they're also clinically relevant using real-world data. And a lot of challenges actually come up from using real-world data, both in terms of size, but also in terms of quality for data pre-processing. So I'm going to frame this talk in the context of three main objectives, technical objectives, just to sort of change the theme a little bit considering the talks that have been presented so far. The first one is to improve model performance, and this is in simple terms, improving model accuracy. Because even though those large language models perform really well because they learn from tons and tons of data, once you get into specific use cases, medical use cases, the data sets are actually much smaller. The second objective is to enhance robustness and efficiency. And the third one is to advance trustworthiness and reliability, because we do also want to make sure that clinicians trust the models that we build and that they're deployed in a safe manner. So let's start with the first one, which is improving model performance. So as you all know, I mean, clinical decision making is inherently multimodal. So clinicians rely on different data modalities. They rely on the patient's history. They rely on their electronic health records data, their medical images, their clinical reports, all to come up with a decision or a diagnosis, etc. So it's a really multimodal decision-making practice. And back a couple of years ago when I started my PhD in this area, we were actually mostly relying on the use of vital signs for early warning models and for deterioration prediction. But since COVID, and I'm mentioning this because I believe it's actually a transition period for AI in healthcare, a lot more emphasis was actually put on other modalities. And that's because during that time, chest x-rays were widely used because they were widely available and they were used as a tool for diagnosing COVID, but also for monitoring patient prognosis. So during that time, we actually decided to take early warning scores to a new phase, which is by introducing medical images. And that's only because images were widely collected. And through this work, we were able to show that by combining chest x-rays and clinical data extracted from electronic health records, you could actually lead to an improvement in performance. And this is why I think multimodal learning is now considered the state of the art, even though it comes with its own challenges when it comes to data integration, collection of multimodal data, because you might face data sparsity or missingness. So there are a lot of low-level technical details that need to be sorted out. But on a high level, I think the key takeaway here is that chest X-rays are useful for early warning prediction. And that's why we decided to look into this further. So when we pursued the COVID work, we actually did a very simple fusion approach. We took the prediction from the EHR, and then we took the prediction from the chest X-ray, and we averaged them. It's a very simple late fusion approach. That's a technical term for it. But we decided to look at how can neural networks better learn from multiple modalities by leveraging the representations or the feature representations that are learned by the neural network. So for those who are familiar with neural networks, neural nets have multiple layers, and each layer computes a new representation of the data. So that's when we looked into joint fusion approaches, and we proposed MetFuse, which is a new benchmark for multimodal fusion using chest X-rays and EHR. And actually a huge component of our work is to also open source the code so we can enable reproducibility and so that others can use our code and build their own models. And then we actually thought about another thing, which is how do we expand this to other tasks? Because for this initial task, we mostly looked at deterioration prediction, in-hospital mortality prediction. So we expanded that and we looked at other hospital-based clinical decision support tasks like predicting length of stay, predicting radiological conditions, and so on. So we introduced a second benchmark repository called MedMod. The paper is still under review. But another important actually contribution of MedMod is that we also explored the use of unlabeled data. So when you think about how the data is collected in the healthcare setting, usually you have, let's say, a breast mammogram and then the ground truth of whether there's cancer or no cancer. But this is a very small subset of your data set because not everyone gets to go through histopathology and get a biopsy and then get the ground truth of cancer. So another thing we wanted to explore here is how do we leverage the unlabeled data? So basically any data point, regardless of whether or not it has the associated label that we're trying to predict. And this falls under the umbrella of self-supervised learning for those who are familiar with the machine learning terminology. We also wanted to explore the impact of multimodal learning in other domains. So we have other ongoing work where we also look at multimodal learning. So this paper is also under review, but we decided here to use OCT imaging of the eye in order to predict the risk of stroke in the future. And the results were very promising, especially that once we incorporated the clinical data, which is as simple as the patient's age, patient sex, comorbidities, and recent vital signs, the performance improved, going from the pink bars to the green ones. And we also compared it to a state-of-the-art foundation model called RedFound, which was published recently, and we also show similar improvements. So again, this all highlights the merit of multimodal learning, despite the challenges, which I will discuss later. So the second aim here is to improve robustness and efficiency. And I'm going to also give you a few examples from what we've done here. So the first one is relevant to model size. So a lot of the models that are being trained right now, especially in the era of LLMs and multimodal LLMs, they use a lot of data. And the cost of using a lot of data is high, the requirement for high compute resources. And actually for many of those state-of-the-art LLMs, they spend millions of dollars to train a single model. And from a sustainability perspective, that won't really be feasible on the long run because we won't be able to spend that amount of money and time for every single model that we want to train using large data sets. So to this end, we're proposing new approaches in order to take advantage of already existing trained models in order to train smaller ones, and to also get smaller models that can be used, for example, on edge or on devices that are have low resources in terms of compute. So if you're familiar with the technical terms, again, I'm just referencing them in case you want to learn more about this. This is related to knowledge distillation. So we take a teacher, let's say neural network or model, and then we distill the knowledge to a student that is smaller in size. And the results were also quite promising. So this paper was published recently. Another capability of AI models is zero-shot learning, which is also now becoming extremely popular in the domain of LLMs. And I think we're lucky that LLMs actually caught traction because they're also bringing attention to a lot of the things that we do beyond LLMs, not just within the LLM research area. So with zero learning capabilities, the goal here is to get the model to perform well even on unseen labels. So the labels or outcomes that were not seen during model training. And we also developed some methodology here in order to enhance model performance for diseases that were not necessarily labeled during training, but the semantic information was similar to some other diseases that were seen during model training. And we were also able to improve performance. The third example of enhancing model robustness has to do with collaborative learning. So in healthcare systems, especially integrated healthcare systems, sometimes the data is fragmented across multiple hospitals. So one hospital, for example, might have a specific modality, let's say MRI imaging only, and then another database at another hospital may have the patients, let's say EHR. In other scenarios, you might have patients visiting a single institution at within the healthcare system, and others visiting multiple institutions within the healthcare system. So to that end, if you're familiar with federated learning, I know there is a talk about this topic as well, which is the idea of aggregating information across multiple clients using some centralized server in order to get a better performing model while maintaining data privacy. So to this end, we actually created a new framework that integrates two concepts in federated learning, which are called vertical federated learning and horizontal federated learning, such that if the patient's data is dispersed across multiple entities, or if the multiple entities also are collecting different types of data, the model is still able to aggregate it. And this is actually a completely new framework. There are some hybrid approaches, but the way that we've designed it is novel. And the paper is also under review. Now, the last objective, which is to advance trustworthiness and reliability, is also one of our key objectives. And I'll start off by giving an example of a study that we did a couple of years ago in collaboration with my colleagues at NYU Langone, where we actually combined the predictions of an AI model for breast cancer diagnosis with the predictions of radiologists. And the radiologists here are listed on the x-axis from R1 to R10. They have varying years of experience. And the main actually takeaway from this assessment was that if you combine the model predictions with the human predictions, you can actually get a better performance in most cases, not for all of them. And this was an important takeaway because it also means that there's a lot of learning to do in terms of how we can get those models to work with human radiologists or human practitioners in order to get the best outcomes for the patients eventually. Now, a second example of some of the ongoing work that we have is how can we improve trustworthiness of these models from an uncertainty quantification perspective? So currently, the way the models are being deployed is that let's say they compute a prediction, cancer, no cancer. But what if we can take this one step forward and for the cancer prediction or no cancer prediction, also assign some quantitative measure of how confident the model is? And this way, the users, let's say the health practitioners or even the patients, can get a better understanding of how uncertain the model is about its own decision making, and accordingly defer the samples that it's most unconfident about to a human expert review. So this is some of the ongoing work that we're doing as well, which is to enhance, with the goal of enhancing model trustworthiness. And finally, one of the projects that I'm very proud of, and we're actually going to post it on archive this week, is Med-Arabic. So many of the LLMs that are being evaluated are being evaluated on English-based benchmark tasks. There are a few Arabic-based benchmark tasks, maybe one or two for medicine specifically. But one of the things that we noticed is there's a huge gap in terms of medical benchmark tasks in the Arabic language. So we actually constructed our own benchmark data set with 7 tasks, and we got them through publicly available resources. We also injected some modifications to make sure that the models are not memorizing certain information, or that to test if they've been actually trained with some of the data that we're proposing as a benchmark. And another sort of really also interesting fact here is that we also used past medical exams that were posted on Telegram by medical students in the region. So this is very clean and new data that the models can be trained on. We evaluated a couple of different, both proprietary and open access models to see how well do they perform on Arabic medical benchmark tasks. And the main takeaway is there's a lot more work to do. And we also looked at different bias evaluation and mitigation strategies. So we injected some bias into the data, and then we evaluated how the model would perform. And then we tried to actually tell the model that there is bias in the data, and we also assessed that. So this paper will also be out soon. So really the main objective here is to build further capacity in AI in healthcare in the UAE and the region. From a technical perspective, we're going to continue to pursue the creation of new novel methodology, and our current actually emphasis is on foundation models specifically using multimodal data. The second goal is to also engage our clinical partners within the local ecosystem, because we really want to make sure that whatever we build is clinically meaningful and relevant. And finally, I think one of the key takeaways that I also discussed with my very close collaborator recently, who's a neurologist, is that we are really only focusing on the stage when the patient gets sick. When they get to the hospital, they have some symptoms, they need some diagnosis or treatment or prognosis tool, etc. But what we're thinking now is, why don't we tackle the full health continuum? So why don't we look at individuals who are healthy, individuals who could be at risk for certain diseases, and then individuals who are sick or are going through rehab and treatment. So that's our next objective now. So if you're interested in discussing this forward, please reach out, because this is something that we're actively working on as a wider initiative in Abu Dhabi and at NYU. And we're also very grateful to our local ecosystem, because, for example, we recently hosted a clinician boot camp on AI in healthcare. And we were worried, actually, that no one would show up because it was after hours. I think it was around 6 p.m. But luckily, it was a full room. I think we were very happy to see that clinicians were engaged and were eager to both learn or contribute to the work that we do. Unfortunately, we are limited in resources. I would love to pursue all projects that are presented, but this is an indication of how the research interest in AI in healthcare is also quickly developing. Obviously, none of this work would be feasible without the amazing team. Some of them are also here. And with our amazing collaborators. So we work a lot with Cleveland Clinic Abu Dhabi, actually starting from some of the past leadership were there. We work a lot with NYU Langone Health, which is the School of Medicine in New York. And some of our collaborators are also at Canberra Hospital and at the ART Fertility Clinics. So I'm also grateful to their contributions. So I'm going to stop here, and if you have any questions, please feel free to reach out or to contact me over email. Thank you.